Thank you everyone for joining us today. We will begin in a few minutes to allow people to enter the room before we get started. Thank you for your patience. For those of you who've just joined us, thank you for joining us today. We will begin in a few minutes to allow people to enter the room, and we will get started in a few minutes. Thank you. Welcome everyone. Thank you for joining us for the NCD Alliance Regional Multi-Stakeholder Dialogue in Southeast Asia and the Western Pacific regions titled Inspiring Change, Putting People First, Shaping Responsive Health Systems for People Living with NCDs in the COVID-19 Era. I'm Noel and I will be your technical facilitator today. Please use the chat function to message anyone with the title Technical Facilitator in their name for assistance. Before we get started, I have a few technical notes to explain. If you would like to contribute a perspective, idea, or thought, please use the chat function. If you would like to ask a question, please use the Q&A button. You can find both of these features at the bottom of your Zoom window. Please note that this session will be recorded for documentation purposes. We are also streaming live on Facebook to enable a larger audience to take part in the discussion. For those of you just joining us, thank you for joining us for the NCD Alliance Regional Multi-Stakeholder Dialogue in Southeast Asia and the Western Pacific regions titled Inspiring Change, Putting People First, Shaping Responsive Health Systems for People Living with NCDs in the COVID-19 era. I will now pass the floor to Dr. Monica Arora, NCDA President-elect, Chairperson, Southeast Asia NCD Alliance, Executive Director, HRIDE, Secretariat of Healthy India Alliance. Dr. Monica, the floor is yours.
Thank you so much, Noel. Good afternoon, everyone, and for others who are in different parts of the world, good morning or good evening. As President-elect of NCD Alliance, I welcome all panelists and participants to the multi-stakeholder dialogue for the Southeast Asia and Western Pacific region, which is being organized as part of NCDA's regional series entitled Inspiring Change, Putting People First. Many of you are well familiar with NCD Alliance. It was founded in 2009 and has developed a robust global network of more than 2,000 organizations in 170 countries. With non-communicable diseases, due to their chronic and sometimes lifelong nature, these require repeated interaction with the health system over long periods of time. And this includes both disease management involving access to essential medicines or rehabilitation services. Not receiving this care often has devastating consequences for people who are living with NCDs, and with the rapid spread of COVID-19 across the world, the ability of the countries to address and respond to NCDs has been severely impacted. We have seen these in many surveys conducted by either NCD Alliance, WHO, and other organizations. The virus has caused broad disruptions to health services, while at the same time drawing attention to countries' NCD burden, as those living with NCDs are at increased risk of becoming severely ill with the virus. So NCD patients and those living with NCDs are already vulnerable to this infection. Putting people first is a priority for NCD Alliance's activities and is informed by our strategic plan. The need for promoting people centered approaches and delivering a people centered healthcare during and beyond the COVID 19 pandemic has been widely recognized as core aim of health systems around the world. In the context of non communicable diseases, adopting this approach has become a central consideration in the healthcare experience of people living with NCDs. More than ever, there is growing recognition among the NCD community that to achieve better health outcomes, there is a need to revisit prevention and health delivery models for NCDs and to ensure they are driven by the needs of the affected population and acknowledge the value of this rich lived experience. So, all of us who are involved in putting people first do value them as experts because they are the ones who would provide this experience which would inform our interventions and programming. Also, to ensure the policy frameworks and health systems become fit for the purpose and reflect a more resilient and sustainable way forward, decision making processes at all levels must include voices of the communities and people most affected. So, in view of this, NCD Alliance has been hosting a series of regional multi stakeholder dialogues across the WHO regions. This has happened during May and June, and a few dialogues are to follow. Today's regional dialogue will seek to discuss region specific people centered approaches to address NCDs, ensuring universal health coverage and leaving no one behind in order to build back better and fairer from the COVID 19 pandemic. Excuse me. Discussions will feed into the broader consultative process, contributing towards a global charter on meaningful involvement of people living with NCDs. So, we would want everyone to discuss in today's dialogue and give inputs which will inform this charter. We will aim to have a shared understanding of the meaningful involvement, its importance, key principles and strategies for implementation, and commitment from governments, multilaterals, relevant private sector, and civil society to embed meaningful involvement of people living with NCDs in organizational practices. You all would have seen the objectives of this regional dialogue. And since we are two regions discussing today, we would like to see what are similarities and how we can build on each other's rich experience. So we'll take stock of the progress achieved on NCDs and challenges faced by our regions in the current COVID 19 context. We will discuss the value of adopting the people centered approach to address NCDs. And we will also explore the different stakeholders, government, multilaterals, private sector, civil society, what role we can all play together in building back better response. And we will highlight successful models and initiatives that have put people first. They have helped further the NCD response and created social impact for communities. So, with these brief remarks, I would like to introduce our moderator for today, Ms. Shobha Shukla. Ms. Shukla is the founding executive director and managing editor at Citizen News Service, a global policy, communication, and advocacy initiative for health, gender, and development justice. She is also the coordinator of Asia Pacific Media Alliance for Health and Development. She has written extensively on HIV, tuberculosis, NCDs, aging, and gender, among other issues. She did her master's in statistics at Lucknow University in India and certificate course in copy and structural editing from the Academy of Literacy Arts and Publishing in Singapore. She received IAS 2019 HIV Science Journalism Fellowship and is a very renowned person in the field of research, journalism, and various health issues. With this, I would like to welcome Ms. Shobha Shukla to take the proceedings forward. Thank you.
Namaste and a very warm welcome to all our participants who have joined from different parts of the world. Thanks, Monica, for your kind introduction and very lucid and pertinent reflections. Monica has been a dear friend of CNS, and we have worked with her organization, Hriday, for over 2 decades, especially in the context of tobacco control, which is so very integral to prevention and control of NCDs. It is indeed a pleasure and an honor for me to be moderating this session, which is part of the series of multi-stakeholders regional dialogues being organized by NCD Alliance in all the WHO regions with the aim of putting people first and shaping responsive health systems for people living with NCDs in the COVID-19 era. COVID-19, as we all know, has brutally exposed the existing fault lines in our health systems, which have been there for long and yet neglected for long. People have had to pay the price of this historic neglect of public health, where people suffered not just because of the coronavirus, but also because of non-availability of timely care for NCDs and other basic health services. The price has been very heavy for not fully implementing life-saving evidence-based policies of tobacco control and other evidence-based measures for prevention as well as diagnosis, treatment, care, and support for every non-communicable disease. We would have been much better prepared to deal with the pandemic if we had been on track to act upon the promises made by governments as envisaged in the SDGs or Sustainable Development Goals about ensuring rights-based access for each one of us worldwide to a full package of standard prevention, diagnosis, treatment, care, and support. Looking forward, we have to ensure that yes, we have lost health and many lives, but we must not lose the hard learned lessons. Right to health must be the central driver as we rebuild a more equitable world where no one is left behind anywhere and people living with NCDs are not forgotten, pandemic or no pandemic. Today's dialogue for the Southeast Asia and Western Pacific region will focus on the meaningful involvement of people living with NCDs from a multi-stakeholders perspective and discuss region-specific people-centric approaches to address NCDs in order to build back better and fairer from the current pandemic. To help us achieve this objective, we have with us today a formidable array of speakers from different sectors who will be sharing their insights and best practice examples from their respective fields. There are three parts to today's discussion. We will begin with reflections from three guest speakers, followed by two panel discussions. Each panel discussion will be followed by a fireside chat in which we will take up questions and comments from the audience. As Noel has already said, participants, please use the chat function to connect with each other and share your thoughts and comments about the session to make it as interactive and lively as possible. If you have any questions to ask, please put them in the Q&A box. We encourage you to send in your questions through the Q&A box even as the speakers present. No need to wait till the end. Please keep your questions short and brief. And please also mention if the question is directed to a specific speaker. And also one last request. We are living in difficult times and many of us are still working from home. So please pardon and bear with any technical glitches beyond our control that might arise due to poor or faulty internet connectivity. Thank you for your understanding and patience. And without any further ado, I would like to welcome and introduce our first guest speaker for today, Dato Dr. Noor Azmi Ghazali, the Honorable Deputy Minister of Health 1 of Malaysia. Dr. Ghazali's career in health spans over 35 years. He started as a medical officer in various government hospitals in Malaysia after he obtained his tertiary education in medicine at the University of Malaya. He has served as the chairman of Perak College of Medicine and brings in a wealth of experience from other sectors to the health sector, as he has also served as the chairman of the Malaysian Highway Authority and has been a member of the parliament since 2013. He was also previously a member of the board of directors of National Health Institute and Forest Research Institute of Malaysia. Dr. Ghazali has been a fervent and passionate leader of tobacco control throughout his career. He is currently leading the task force of strengthening the control of electronic cigarettes in Malaysia, as well as quit smoking programs in the country. He also champions partnering with civil society organizations to achieve bigger goals and supports meaningful involvement of people living with NCDs. Sir, it is an honor to have you with us today. Your work indeed represents a multi-sectorial approach, which is so very essential to tackle NCDs. Can you please share with us how the COVID-19 pandemic has been a light bulb moment for public and political perception of the importance of investing in NCDs and prioritizing the needs of people living with NCDs as part of the national COVID-19 response in Malaysia? Over to you, sir.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. Good morning, good afternoon, and good evening, ladies and gentlemen. Let me begin by thanking the NCD Alliance for convening this series of consultations and giving me the opportunity to participate in this dialogue today. Putting people first means to listen and to respect the views of the people, to give them clarity that is reinforced by a set of actions that prioritize people above everything else. It means to make them feel valued and cared for so that they are motivated and engaged to work towards the same goal. This is especially relevant in the context of tackling non-communicable diseases or NCDs. People living with NCDs are faced with numerous challenges and stigma. Oftentimes, we only see the disease and not only the person living with the disease. Oftentimes, we consider them making poor lifestyle choices, and it is easy to forget. It is the wider determinants of health that influence behaviors of populations. NCDs affects vulnerable groups of the population disproportionately, and oftentimes, policies and interventions overlook these vulnerable groups. Ladies and gentlemen, there are many challenges in adopting a people-centered approach when it comes to tackling NCDs in our region. There are several changes that I would like to highlight. Firstly, a people-centered approach requires a whole of government and whole of society approach. Everyone must be involved, not only the Ministry of Health and not only the health sector. Even in my country, Malaysia, this is an ongoing challenge to put health in all policies. Secondly, many countries in this region are developing countries. Malaysia is an upper middle income country and we spend about 4% of our GDP on health. Although we are proud of our healthcare system and successes, we knew that we need to spend more on health, and we know that our current healthcare system will not be able to cope with the increasing burden of NCDs and an aging population. Malaysia is not unique in this sense. Many countries will need to increase spending on the health and need to transit to a healthcare system optimized for chronic care deliveries. Thirdly, our population has low health literacy. It is challenging to empower people living with NCDs to take on more responsibilities in managing their health when their health literacy is poor. In Malaysia, an estimated a third of the adult population has low health literacy. Many countries in this region are also facing the similar problems. Ladies and gentlemen, when the COVID-19 pandemic hit our region, it had amplified the disparities and inequalities that are the underlying causes of NCDs. the pandemic had also negatively affected the life and the management of people living with NCDs, more so for vulnerable populations. Not only that, but within Ministry of Health, we had to shift our energy, attention, and resources to fight the pandemic, while NCDs, unfortunately, took a backseat. However, the pandemic also enhanced several developments. Let me highlight some of these developments. Firstly, as a region, we have long focused on economic growth, and only now there is more understanding and acceptance that health is necessary investment. Now, many different government ministries and agencies are working together towards a common goal in health. Secondly, we finally welcome greater use of digital technology in healthcare. In Malaysia, adoption of digital health interventions was accelerated during this pandemic, despite having spent many years before this discussing. We developed more effective ways to deliver healthcare services through this pandemic using digital health interventions, even with the limitations of our current healthcare system. Thirdly, we came up with creative ways to collaborate with the private sector and the non-profit sector. The private hospitals help provide additional capacity for non-COVID related operations when the public hospitals were at maximum capacity. The non-profit sector has helped play a huge role in tackling domestic violence and mental health issues, both of which have increased during the pandemic. It taught us that public, private, and non-profit partnership is a relationship that we can leverage on to solve greater problems together in the future. Lastly, we have come to realize the importance of good strategic communication. Many countries have tackled the COVID-19 infodemic aggressively by increasing accurate health messaging, exposing the fake news, and imposing punitive measures on those acting against the greater good. Through these intense health education interventions, the public has adapted to better hygiene practices and indirectly increasing the level of overall health literacy of the population. Ladies and gentlemen, in every step of the way in managing the COVID pandemic, we have developed strategies either consciously or subconsciously that put people first while maximizing limited resources. This is in line with the United Nations General Assembly Omnibus Resolution on COVID-19, where the need to put people first to build back better and fairer was recognized. Moving forward, newer strategies in tackling NCDs will and must build on the strengths that we have today. We must continue to fight to integrate health into all policies and continue to close collaborative work with ministries and agencies outside of health. We must also continue our collaboration with the private sector, non-profit organizations, and civil society, while at the same time manage conflicts of interest and maintain transparency and accountability. In addition, we must quickly adapt digital infrastructures to make NCD management easier for our people. We need to control and prevent NCDs using some of the strategies that were used for COVID-19. We must urge our people to deal with NCDs with the same agency as they had with COVID-19. There will come a time when we need to transit a post-COVID-19 world, and we need to take every opportunity to shift that focus back towards the NCDs in order to reach the health targets of the Sustainable Development Goals. Let us not forget that there will also come an immediate and prolonged wave of NCD-related problems. Firstly, with those presenting late with NCD complications, loss to follow up due to COVID-19, and later with those presenting with mental health problems due to increased social inequality, economic injury, and job losses. In bracing ourselves for this future, let us all take a reflective moment, build on our strengths, and learn from each other through this crisis. Ladies and gentlemen, to conclude, I wish to once again remind all of us that we should never let a crisis go to waste. Health systems around the world has been challenged. We bend, but we did not break. Together, we had developed some strategies that put people first as the answer. As we continue to face the COVID-19 pandemic, may we all come out of it stronger and better primed to tackle NCDs, which will remain as the overarching challenge of our decade. I wish you all a fruitful discussion today. Thank you very much.
Thank you, sir. Thank you very much. Yes, we stumble, but we get up again and we move forward. And I now invite Dr. Palita Abekun, Senior Advisor in the Sri Lankan Ministry of Health. A physician and public health professional, Dr. Palita has earlier served as Director of Health Systems Development at the WHO Southeast Asia Regional Office. He also chairs the National Authority on Tobacco and Alcohol, serves on the National Advisory Committee on Communicable Diseases, and is a member of National Medicines Authority of Sri Lanka. He has worked as a consultant and advisor in many countries, including Nepal, Indonesia, Thailand, Myanmar, and India, and is the recipient of numerous international academic awards. Welcome, Dr. Palita. Dr. Palita, given your wide knowledge and experience, can you please share with us how the COVID-19 pandemic has showcased the importance of exploring people-centered models for NCDs in the light of realities of the region and recovery efforts?
Thank you very much, Ms. Shobha, for your very kind words. Good morning, good afternoon. First of all, let me thank the NCD Alliance and Ms. Monica for this privilege of sharing some random reflections at this very important bi-regional dialogue. The word reflections gives me some latitude. The unprecedented COVID-19 pandemic has seriously affected all areas of our health systems, not just infectious diseases and critical care. In fact, it has acutely affected all aspects of life and livelihoods. Patients with NCDs continue to bear a disproportionate burden of both COVID-19 itself and of the public health measures like lockdowns. Long closures of community screening, healthy lifestyle clinics and primary care facilities, and redeployment of regular NCD staff to COVID-19 work have had serious impact. All these are coming in a context where in low and middle income countries, particularly, large numbers of people living with NCDs have difficult access and get suboptimal treatment even under normal circumstances. There are already more dead from COVID-19 in 2021, these 6 months, than in all of 2020. 75% of the COVID deaths in most countries have been among high-risk groups, those over 70 years with comorbidities, causing a huge social and economic disruption. What then are some of the COVID-19 related people-centric responses that some of our countries in Southeast Asia adopted? I'll offer a small sample of policy and action level reflections on how governments and the non-government sectors address some of these challenges. Ladies and gentlemen, while overall the NCD related responses keep evolving, one clear feature has emerged. Those countries that have strong primary healthcare services and community level support systems have been able to meet the needs of the people with NCDs much better than others. The pandemic did stimulate many innovations. The key focus areas, as we heard before, were use of technology for care and communication and awareness raising, home screening, a fast-track system with infection prevention and control measures to protect the NCD patients. The value of digital or telehealth got highlighted during the pandemic in most of our countries. Use of telemedicine skyrocketed in most of the countries also. COVID-19 has triggered many new communication and tracking tools that have been fundamental to the work of community organizations and helped to minimize in-person consultations. More and more NCD patients now use telecommunication via audio, radio, video, or e-chat to contact their doctors and clinics, both in the government and private sectors. Further, communication and risk communication with the community expanded with the use of these devices. In Sri Lanka, Nepal, Bhutan, India, and Thailand, the ministries of health and often with WHO worked very closely with civil society partners, most of them members of the National NCD Alliance, and introduce innovative mental health interventions, setting a benchmark on the optimum needs. During this period, many programs to stop or reduce tobacco and alcohol use were introduced. Online training of health staff is now popular and is undertaken very widely. Another innovation was the delivery of medicines to patients' homes with the support of the private pharmacy owners and volunteers. Very specific area where we see NCD alliances and CSOs are helping now is with regard to vaccination of the elderly with NCDs, eliminating language and transportation barriers and reducing vaccine hesitancy. In fact, we need to accelerate the vaccination of those with NCDs as a priority. The COVID-19 virus itself does not discriminate, but it has exacerbated inequalities within societies, and health systems are not very well equipped to respond in an equitable manner. Vulnerable groups suffer the most. We see this also in the current vaccination drive. A few countries have not yet vaccinated a single citizen, while some are approaching herd immunity levels. We all should commend Dr. Tedros, the DG of WHO, who is strongly articulating to eliminate such inequalities and prevent health from becoming yet another commodity. Ladies and gentlemen, let me conclude now. Firstly, the overall, the NCD Alliance, I think, can play a significant role in mitigating and ending the pandemic itself by inspiring change and putting people first. This is central and cardinal. It is the virus that is the problem. People are the solution. COVID-19 crisis in general and NCD services in particular give us an opportunity to give a stronger role to civil society organizations and the private sector, in fact, the whole of society, to complement government services and to empower the community. And finally, all of us should advocate equitable, people-centric NCD initiatives built on PHC principles under the universal health umbrella. Then, during COVID, as well as afterwards, people with NCDs will receive adequate and equitable care in a fairer and healthier world. Ladies and gentlemen, in these rather gloomy days, most philosophies advise us not to fret and curse the darkness, instead to burn a candle and march on. Thank you very much.
Thank you very much, Dr. Palita. And thank you for focusing on vaccine equity, because that is an integral part of health equity as well, which is so very essential for people living with NCDs. Our next speaker is M. Farley Andrew Leza. Farley is a member of both the Governing Council and the Executive Leadership Team at NCD Child, apart from being on the boards of many organizations working on NCDs. Indigenous to the small island of Samoa, Farley is now an immigrant in New Zealand. His lived experience of NCDs inspired a career in governance. He's passionate about equity in healthcare and is acutely aware of the challenges facing Indigenous communities. Welcome, Farley. And we are really keen to listen from you on why people and communities must be center stage in building back fairer from the COVID-19 pandemic and how to ensure their meaningful involvement. Over to you.
Thank you very much, Doctor, and warm Pacific greetings to all our listeners today. COVID-19 exposed a number of fundamental challenges in the way that we administer healthcare. Namely, that we're overburdened by two things: the politics of healthcare and the cost of healthcare. This meant that we failed to invest in prevention or in crisis management, despite the overwhelming evidence in their favor. Going forward, we must put people and communities first. and prioritize early warning systems so that we're ready for a future pandemic. Right now, the world is still recovering from the horror of COVID-19, and there's a lot of distrust towards the system. A people-driven recovery will help restore faith and build confidence in the system again. Building back fairer means involving those who have been left behind, like the rural poor, those with disabilities, and our indigenous communities. Meaningful involvement is about long-term partnerships and not short-term assignments. We need to support structural changes to the system, and rather than tinkering around the edges. Half of all mental illnesses begin before the age of 14. Most people smoke their first cigarette and experiment with marijuana for the first time at school. By putting people first, we have a fighting chance at stamping out the very behavior behind non-communicable diseases. To treat them early means we are saving more lives and saving more dollars. For people of color, healthcare isn't a commodity. It is a way of life, and it applies to our spirituality, extended families and communities, as much as it applies to our bodies. The failures of COVID-19 are the manifestation of the failures within our healthcare systems. The failure to provide the same quality of care for everyone. When I facilitated a Youth Leaders in Action webinar last week for NCD Child and AstraZeneca, the young people spoke about their desire to co-create and co-lead. They are tired of organizations half-assing youth engagement. Give them the space to influence public policy and to drive service delivery. Give them the space to grow as emerging leaders. Trust that they are capable of taking on more responsibility, especially in a digital environment. There are more young people on the planet today than any other period in the history of mankind. It is our single greatest asset when combating non-communicable diseases. To give healthcare a human face, we must start with our youngest. This will create the conditions for a paradigm shift. I am optimistic. Everyone in this room is optimistic. That's why we do what we do every day. Winston Churchill said, never waste a good crisis. COVID-19 doesn't have to be a story of tragedy. It could be a catalyst for more meaningful engagement on healthcare and for more equity. But that largely hinges on how well we organize as a sector right now. It is absolutely imperative that we don't squander the opportunity that lies before us. Utilize the global cooperation, utilize the urgency to ensure that nobody gets left behind. That's what it means to put people and communities first. It's about giving them the dignity of choice, the dignity of care, and the dignity of recovery. Don't treat them as a barcode, don't treat them as a number, don't treat them as a funding application, but treat them as humans with dignity. That is the opportunity before us, and together we can help realize that potential. Thank you very much.
Thank you very much for your reflections, Fale. And thank you for saying that we need to have a rights-based approach while involving people, treating them with dignity. Participants, if you have any questions for Pali or Dr. Palita, please send them via the Q&A box. They will be answered during the first fireside chat. We have heard from our guest speakers, and we now move to our first panel discussion on shaping the future of NCDs by putting people first, a regional perspective on the importance of community-driven approaches. A very warm welcome to our two esteemed panelists, Dr. Sauntari Somasundaram and Ms. Jyotsna Govil. My first question would be to Dr. Sauntari Somasundaram, who is chairperson of NCD Malaysia and president of the National Cancer Society of Malaysia, which is the oldest cancer NGO in the country. She was conferred the Darja Datuk Paduka Mahakota Perak Award by the Sultan of Perak in 2020 for her services in cancer and NCD control. Sauntari, in your opinion, how has the COVID-19 pandemic revealed the need for more meaningful involvement of civil society and people living with NCDs to ensure people-centered health and development plans for prevention and control of NCDs? And please share some examples also. Over to you.
Thank you so much. Warm greetings to everyone. I'd like to talk this afternoon a little bit from a CSO's point of view in terms of how policies impact the work performed by CSOs pre and post, during this COVID pandemic. Just a brief talk on Malaysia's NCDs programs. Malaysia has had a strong consolidated national plan for NCDs since 2019, providing an overall framework and strategies to prevent NCDs. The challenge, however, felt by all of us was perhaps the implementation of these strategies within government and the larger societal framework was a little bit weakened. This was reflected by WHO in 2019, who pointed out that Malaysia lacked an operational multi-sectorial action plan. And coming from the CSO point of view, we were in the fringe, we felt, of most strategies. However, there's one exception, an incredibly cohesive action, and we applaud the ministry for this, and that was in tobacco control, in which CSOs and MOH worked closely on programs in the country. So in 2019, NCDs were already the leading cause of mortality, and Malaysia's health system was barely coping with the increasing disease burden. As in all countries, the reasons for the disease burden are multifactorial, but one which impacted during this COVID pandemic is really the ineffective usage of resources, with disease diagnosis and treatment undertaken in secondary and tertiary institutions instead of primary health care. Thus, hospitals were overloaded, causing delay in care. Additionally, there were no pathways for shared care between primary and tertiary health systems. And as our minister mentioned before, investment in healthcare was a low political priority and needs to be beefed up. So with that landscape, the COVID pandemic was literally the straw that broke the camel's back. It really highlighted and amplified the gaps and strains in the health systems to the detriment of people living with NCDs. In a recent study done on NCDs and COVID hospitalizations, it was shown that 25% of those admitted with COVID cases had at least one comorbidity. And of those who died, 87 of them had at least one comorbidity. So people living with NCDs were suffering a double burden. The diverting of healthcare services towards dealing with the pandemic also pushed NCDs to be a low priority. So what was that societal impact of this policy? People living with NCDs were basically shamed for thinking their disease burden was equally important as preventing COVID. This situation was not unique to Malaysia. Very few countries, regardless of how advanced its healthcare system is, did differently. In trying to safeguard people with comorbidities, we unintentionally belittle their needs, causing irreparable harm to many seeking early diagnoses and treatment of NCDs such as cancers, delays which push some to later stages and preventable deaths. And though government directives to ease this healthcare access developed over time, because of the lack of clarity, it created quite a lot of confusion and fear in people. So with these issues in mind, CSOs tried to fill the gap. Some services that we gave were a dedicated hotline to patients to address the fears of COVID and the disease. And now during the vaccination phase, many with comorbidities are fearful of the interactions and the impact of vaccinations and require counseling. We assisted in reorganizing appointments, providing letters, etc., for ease of travel. In the prevention and diagnostic aspect, we provided diagnostic services. We became a conduit between public and private healthcare, decreasing waiting times for diagnosis. We initiated patient treatment access programs for those who had financial constraints. And a major key was health promotion, was increasing health promotion via virtual platforms, Zoom, social media, etc. Support services have always been there, but we had to ramp it up in different ways to amplify the voices for patients and the counseling aspects of it, even going down to the provision of PPE and other items to at-risk populations. And lastly, I think, where we really had to also focus, even though most of the focus was on COVID, was that we had to play the role of a watchdog to ensure that current policies, such as tobacco control policies, are enforced. Industry has taken advantage by increasing direct and indirect promotion through COVID relief CSR programs and financial support. And we need to shine a light on actions such as that. With vaccinations ongoing now, we try to complement government initiatives by developing programs to reach those at high-risk populations through house-to-house vaccinations, mobile vaccinations, through mobilizing medical and general volunteers across the country. So lastly, the lessons learned. The pandemic is not an excuse to relax our commitment onto NCDs or to whitewash the poorer outcomes of higher morbidity and mortality that we are having during this pandemic. As mentioned by our minister, there needs to be more investment in healthcare. Pandemics will be here to stay in different reiterations, but the NCD fight is a marathon. It's not a sprint. So we need to reevaluate our healthcare processes, and we need to build on a stronger primary healthcare as being front and center to maintain the continuity of care for patients with NCDs. So I think I'll end there. Thank you very much.
Thank you very much, Santari. And thank you for focusing on primary healthcare. And also that having proper policies in place is the first important step, but implementing them at the ground level is equally and rather more important. I would now request Ms. Jyotsna Govill to share her thoughts. Jyotsna is a strong advocate for NCD prevention and control and has done exemplary work in the field of cancer care and control. She has been guiding the India NCD Alliance since its inception as a member of its governing board, particularly on work related to involvement of people living with NCDs. She also serves on the governing council of the Indian Cancer Society and is a member of the advisory committee of Our Views, Our Voices. And she has innumerable awards to her credit. Jyotsna, as a person living with NCDs, what does a people-centered health system mean to you? And why is it essential to address NCDs, ensure universal health coverage, and ensure universal health care as well, and resilience and recovery from COVID-19? Can you also share any examples reinforcing the case for meaningful participation of communities and civil society and people living with NCDs in the COVID-19 response?
Thank you, Shobha. That's quite a broad spectrum that you've asked me to cover, so I will do my best. I think COVID is foremost in everybody's minds, And I guess it would be the best thing to start right there. As every speaker has highlighted, we neglect public health systems at our peril. Those countries that had a strong public health system handled things much better. But in the reality of our world, there are huge inequalities within each country, never mind between one country and another. Within India, we know that there have been pockets where excellent care has been given. And equally, there are other parts of the country, some states, that have not risen to the occasion at all. Now, what is so tragic is that India had a very good record of battling things like smallpox, which they have eradicated, of polio, which has been eliminated to, I think, almost 100%. And so we had the systems. It was simply that they were allowed to drop. And there was a sense of complacence because the first COVID wave had been handled pretty well. So what did we see during COVID? We saw the best and the worst of human behavior. There were people who made a completely unreasonable benefits out of other people's health and deaths, and others who came forward to help in every possible way. We know of community kitchens. We know of people cooking in their homes and helping out with families who were in trouble. We know of people who recognized that mental health was a very important part of a disease which involved people being shut up in their own houses with no company, with no one to talk to, and who worked day and night to provide those kind of services. So I would say that COVID was not a completely dark scenario. There were rays of light, which I hope I have been able to highlight very quickly. Now, I have been in a care partnership for over 35 years. And again, I think that we had in position in the Indian Cancer Society a very good emotional support group. We call it Cancer Sahyog. It's not leading anyone. It's not following anyone. Sahyog is someone who walks with you and who is your partner. So we have had that in place for 35 years. COVID certainly gave us plenty to think about because our volunteers are all cancer survivors or caregivers, people who are vulnerable and therefore could not go to the hospitals. But we have found ways of using the telephone, using Zoom, using WhatsApp to keep in touch with most of our clients and to keep giving them the kind of support that cancer patients required. Yes, many people have highlighted that patients could not get to hospitals because the emphasis was on COVID. And even those that were given appointments were apprehensive about going into a crowded public place where they could contract COVID in addition to what they already had. But one way and another, our volunteers spoke with the doctors, counseled the patients, and ensured that at least some, I will not say all, were able to meet with the doctors or get the advice from the doctors. Telemedicine has played a huge part in every country of our region, and that is true of India as well. we've also used the COVID lockdown period to build our own collaborations. And we're talking to different organizations to try and build special educational packages to build up on training that every organization needs. And so when we say consult, advocate, involve, and amplify, that is precisely what we have attempted to do with various plans and schemes of our own. We have recognized the need for an alliance of non-communicable diseases. And this is the reason that we have been active in the Non-Communicable Disease Alliance in India. We believe that nobody can say that they only have the one disease. Just for myself, I'm an old woman. I would appreciate, and I think it was the minister from Malaysia who said that there were a great number of elderly people for whom care was required, and all of that with various other comorbidities like a mild diabetes and so on. Nobody is ever a single disease person. We need to know that what is happening to us is happening in the system, that we cannot work in silos, and that we need to work together. So let's connect those dots and ensure that we have a good system working. Thank you very much.
Thank you very much, Jyotsna. It's so important to connect the dots and to walk with each other in solidarity, as you said. But I don't agree with one point of yours, and that is you are old.
Oh my goodness.
I cancel that. that is not true. You are so young at heart, and that is what is important, I think. So
thank you.
So sorry for saying that. So I'm sure the rich contributions by all the panelists has given us enough food for thought, and we are all set to begin our first fireside chat. And the place where I am, as I said earlier, the temperature is 31 degrees, feels like 41 degrees centigrade. So I would like to invite Magyanta Suraman, or he wants to be called Gyan, to please break the ice with his intervention and set the stage for the Q&A session. And meanwhile, participants, please keep on sending your questions via the Q&A box. For the panelists, as well as for our guest speakers, Dr. Palika and Pali. Yes, Gyan. Now, okay, sorry, let me introduce Gyan first. Gyan, as he's popularly known as, currently works as the Young Leader Consultant for UNICEF Young Health Program in Indonesia. He's a spokesperson for the youth movement for FCTC, the WHO Framework Convention on Tobacco Control, focusing on tobacco control for and by the youth from a global health perspective. He's also on the UNFPA Youth Advisory Panel to promote youth participation in development issues, particularly on comprehensive sexuality education. Over to you, Gyan.
Thank you very much, Ms. Toba, for the greetings. Hello, everyone. I'm Gyan. I'm from Indonesia. It's been a pleasure for me to attend this meeting and listen to many of your experiences, many of your commitment, and of course, critical perspectives on health and equity for all. So as been mentioned before, I'm the Young Leader Consultant for the Young Health Program UNICEF AstraZeneca's partnership, but basically with the UNICEF in headquarters New York. So I'm working at the global level to make sure that we can recruit young leaders who are passionate in preventing NCDs and promoting health for all, and with all of their initiatives meaningfully, of course, with meaningful youth participation. One thing about meaningful youth participation, I think we have to acknowledge first that when we involve young people in any health intervention programs, whether it's a campaign health or research or advocacy, we have to acknowledge that there are many kinds of young people and many kinds of backgrounds, gender, sexualities, race, and regions. So there is no one size fits all, not only for youth in health programs, but also for any, I think, development or global health agendas. So we have to acknowledge the complexities and the needs of young people, especially young people with living with NCDs. Regarding people living with NCDs, I'm a tobacco control advocate since 2015, engaged, very active in national and international networks. But my experience and my motivation comes from my own grandfather. So he died of stroke. He was a heavy smoker, and even his last words were, "I need cigarettes." So that's what motivates me as a young person, so that my generation doesn't have to go through that kind of experience of spending years of your life in your home, being taken care of by others, and also, of course, with the burden of economic and social burdens that comes entail with that. So I think we need to support as well people living with NCDs, especially young people living with NCDs, because it's a sad thing to say. It's kind of bizarre now, like we're saying young people living with NCDs, and it's becoming more common. In the past, we think this is a common for more senior people, but now more and more, especially in global South countries like my country, Indonesia, younger and younger people are, become a victim and living with NCDs because of unhealthy products, unhealthy behavior. But I think we need also to recognize that unhealthy behavior of individuals comes from some kind of, like what Lindsay McGuey says, like a strategic ignorance, from the elite ignorance. So what is elite ignorance? Elite ignorance is basically when the stakeholders who are in favor or in control of many people's lives and well-being and their public health is making an ignorant decision not to choose health, but to choose profits, but to choose any other way to actually accumulate wealth, etc., at the expense of many people's health. So I think rather than only seeing unhealthy behavior and unhealthy products as individual behavior, we have to see it as a structural perspective, in a structural manner. What kind of policies, public health policies, they are in favor to actually curb the marketing of unhealthy products. For example, in my field, my specialty was tobacco advertisement, promotion, and sponsorships. That is pretty much very free in Indonesia. We have young smokers, child smokers, baby smokers as young as 2 years old in Indonesia. And it's a common thing here because it's very cheap, it's advertised everywhere. And that kind of structural aspects, making the affordability of unhealthy products, and then making the consumers, the young consumers, become prone to NCDs, is actually how we should see the lens. And I'm here talking to my fellow youth advocates here. It's not enough only to promote healthy lifestyle. We must also to see the structural perspective of global health, of public health, of people around us. It's not enough to change the behavior of individuals. We must also support policies so then we can change behavior of a nation through their policies. So I think that comes from my perspective, my experience. We gathered 11,000 letters for the president of Indonesia in 2016, and he ended up making a cabinet meeting on FCTC because of young people gathering letters. And then we did many other creative campaigns as well. I think until at one point we were invited to One Young World, supported by AstraZeneca's Young Health Program as well, to deliver our work in grassroots level, how we change local regulations, local laws by youth-led campaigns and research and advocacy. It is possible, it is doable, as long as we involve young people in a very meaningful manner. So I think we just need the chance, to try. And I think cross-sectorial perspective is a good start to do it as well, multi-stakeholders. But of course, we need to also talk about the elephant in the room, which is accountability. So cooperation among sectors always have to be, conducted in a way that we still uphold each other's accountability as much as possible, because we cannot only see it from a charity mindset. We must also see it as health is not only a commodity or an interest of certain stakeholders, but it is a duty for us to the people, that it is a public need, not a commodity. And I think it's about time for us to build a new normal that prevent NCDs, that choose health over profits, and young people can do that through meaningful youth participation, especially those living with NCDs. I think that's my part. Thank you, Ms. Soba.
Thank you very much, Gyan, and thank you for leading the fight against big tobacco, because tobacco use, as we know, is a totally avoidable risk factor for so many NCDs. And it is very important because the big tobacco is also inducing and encouraging young population or young customers every year to have their lethal product. So thank you for bringing that up. Before we move on to the Q&A part, I now invite Mario Villaverde, I hope I'm pronouncing the name correctly, who's Undersecretary of Health in Philippines. He supervises health policy development and strategic planning, health human resource development, local health systems development, and international health cooperation. He oversees the institutionalization of policies on universal health care and health sector reforms. He's our special invitee speaker for today, and he also teaches public policy and health governance at the Ateneo de Manila University School of Government. Mario, how can we ensure social participation and meaningful involvement in building resilient, people-centered health systems and emergency preparedness plans? Over to you.
Thank you, Ms. Shoba, and thank you, NCD Alliance, for inviting me to this forum. The unprecedented COVID-19 pandemic highlighted the gaps in the health system and the importance of implementing our universal healthcare law. The said law mandates the establishments of province-wide and citywide health systems that would contain networks of healthcare providers. Such network would provide both population-based and individual-based health services with emphasis of primary care at its very foundation. Now, population-based relate to health packages where population groups as the main recipients or sectors of the population. This will include health packages related to health promotion, disease surveillance and epidemiology, disaster risk and health emergency management. On the other hand, individual-based health packages are services that can be traced back to a single individual and has limited effect at a population level. This will include general hospital-based and ambulatory medical and surgical packages. Now, people living with comorbidities, such as NCDs, are more susceptible to COVID-19 and possibly other diseases. It is important to prioritize the needs of these people to prevent further strain on the healthcare system amidst our pandemic now. Providing preventive health services and environments that promote healthier lifestyles is imperative to stop development of NCDs in our communities. On the curative or management side of NCDs, our social health insurance must expand the benefit packages to include a wider perspective of non-communicable diseases, and all these are envisioned in our recently passed universal healthcare law, which provides major sources of funding to provide these benefit packages. The first is, of course, from the sin tax collections, which include taxes on tobacco, alcohol, and sugar-sweetened beverages. The other major source are the government share from our amusement gaming, our charity sweepstakes, and Lotto. Along with this, we are prioritizing in our response to COVID-19, our frontline health workers, the people living with NCDs and other comorbidities, particularly in relation to the provision of COVID-19 vaccines. These people are also advised and excused to stay and work at home for the duration of this pandemic so that they are not unduly exposed to COVID-19. Now, a whole of society approach towards achieving universal healthcare is enshrined in our law. Numerous public consultations were conducted during the development phase of the law, involving all health sector stakeholders. This includes the strong participation of our civil societies, which have major role in the health promotion strategy, as well as in performance monitoring in relation to the implementation of our universal healthcare law. So to summarize our key messages, our universal healthcare law specifies the package of health services that our citizens are entitled. And these are classified into two major types: population-based health services and individual-based services. The law also clarifies the financing mechanism of these healthcare packages, the social health insurance package for individual-based health services, and our government budget allocation, both from the national as well as the local government, for our population-based health services. It also emphasizes the sources of funding. Foremost is the syntax to provide better premium subsidies to our people, and sources from amusement gaming to improve the benefit package. And lastly, COVID-19 pandemic highlighted the gaps in our health system and the importance of implementing our universal healthcare law, particularly in terms of the prevention and control not only of communicable diseases exemplified by COVID-19, but most specifically non-communicable diseases, where most of our high-risk population includes non-communicable disease patients. So that's all, and thank you.
Thank you very much, sir, for your very pertinent and special inputs. You've really raised some very, very important points. And now we move on to our Q&A session. We already have many questions. The first question is for Dr. Sonthuri. Could you please elaborate more on how people with NCDs were affected by the emphasis on comorbidities feeding into COVID-19 severity and death? You mentioned shame also. This is part of the question. Yes.
Thank you for the question. I'll answer on the aspect of shame. When COVID first started, there was quite a lot of stigma towards people who developed a COVID infection, especially during the lockdown time, because you thought that, oh, those people weren't following the, SOPs, and they were having risky behavior in developing COVID infections. So thus, for those who had NCDs, who were more susceptible to COVID, there was a stigma associated with it. But the second aspect of the shame was really that for those who had NCDs, who wanted to continue their appointments, who wanted to go for diagnostics or investigations or treatment appointments, etc., felt that because resources were supposed to go towards COVID, by them actually going for their appointments, they were being, I suppose in a way, they felt that they were taking away from the COVID reaction. They weren't actually helping the COVID cause by taking away resources from COVID so that they could go into their appointments or their investigations, etc. So we actually shamed them in that sense by them wanting to continue with their management during the COVID time. And I think things like this cause people to step back and forego their appointments because they feel that the resources should go to COVID and not to them. And that's what I meant by shame.
Thank you, and thank you for bringing that point up very well, Songthari, because that has happened in many other countries as well. The second question is for Gian. The youth tend to believe they will live forever. So how can we get young people to care about their health while they are still in good health in practical terms?
Right. Thank you for the question. So I think the key of involving young people is, once again, there is no one size fits all. There are several characteristics. Some of them will be very happy to be involved in any activities. And some of them might, feel like, what is the need for me, to be involved because I'm healthy and etc. So basically, I think we need to also, first of all, we have to set the right paradigm, the right development paradigm towards young people and youth participation, because some paradigms see sometimes like youth as the center of the problem, youth as the main problem, like, like this kind of stereotypes, like they don't know what's best for them, or like they think they will be young forever. I'm sorry, but that is also like not, I wouldn't say it's a right approach to say it. That is our assumption that they think they feel young forever, etc. But apparently, once again, we have to acknowledge and take a closer look at the social determinants in health and commercial determinants in health and the public health policy surrounding that young people, even on the very grassroots level, maybe from local leaders, from local religious leaders, etc. Because I'm speaking this from my experience working with the Young Health Program. At the time, it wasn't with UNICEF, but it was with Plan International in Indonesia. I worked there for 3 years. I was assisting young leaders, actually from the age of like around 13 until 17 years old. And many of them are still young, of course. And when we go down to the grassroots communities, to the local communities and to their own schools, apparently sometimes they think like they don't need the health interventions because they just simply nobody hasn't told them yet, and nobody has given them the chance to actually exercise their agency and try to be involved in this kind of participation. And most of the time when they are actually involved in this kind of intervention about health promotion, NCDs prevention for young people, it's not meaningful participation. Some of them are just, just come to this program and use t-shirts and take a good picture so then we can report them to our donors. Right, but it's a difference. So what we did that day, or actually we did like a 3-year span of program. We started with educating the parents as well. We educate the teachers as well. We created an enabling environment first, and then we train the young leaders. So then when the young leaders are being trained, they have the knowledge, they have the support, everything they need to actually exercise their agency. So then they feel more at ease, and this sudden realization that it is urgent for me to learn about health, to keep myself healthy, etc. It's becoming supported by the surrounding environment. So I think more than asking what can young people do, we have also to ask ourselves, what can we do for young people to make them able to speak freely, to have a positive perspective on health promotion, etc., and to exercise their own agency. And at the end, they only need a chance, to try, to fail, and to learn, because we are all learning eventually, not only young people, but also the seniors and everybody else. I think in this meeting, we're always on the ongoing process of learning. So I think it's about acknowledging the context around the young people, creating an enabling environment, and give them the space to exercise their own agency, so then they can try and find the best way for them to promote health, to do healthy lifestyles, etc., according to what they like and according to their needs and according to their own context and enabling environment. So maybe that's my answer, Ms. Soba. Thank you.
Thank you very much. We have another question, and that is not any speaker can answer that, and maybe more than one speaker can give in their inputs. How can we make use of lessons and infrastructure from the COVID-19 pandemic to get the public to be more aware of their own health and the need to get any NCDs diagnosed and treated early? So this is again about health-seeking behavior of the public. Would any of our esteemed panelists like to answer that? Jyotsna, would you like to?
Yeah.
Please.
Yes, I think that COVID has brought many lessons to the general public. And first among them is that each person is responsible for their own health, and that we cannot sit there pointing fingers at CSOs or the governments or the hospitals that they did not deliver, that they did not do whatever. So now the general opinion is that each one of us has to be careful about how we live and eat and even breathe for most part. So if with that kind of a realization, I think it is also a great time to be talking NCDs, because these are not diseases that are communicated. These are diseases that depend on how we live. And that is what the message that we are all taking forward.
Okay, thank you. Thank you very much. Dr. Palita, would you like to add something to it? Is Dr. Palita there? Is he there? Is Dr. Palita, or is he left? And I would also request Fali to please give his reflections on this question. Are they still there, or maybe they have left? Okay, so and now thank you, participants. We come to the end of our first panel discussion, and now our second panel discussion is focused on exploring solutions to mobilize communities in the Southeast Asian and Western Pacific regions for a people-centered response for NCDs in the COVID-19 context. We have 4 panelists for this session: Professor Vivekanand Jha from India, Dr. Lee Thi Thu Yen from Vietnam, Michelle Arvi from Singapore, and Maria Fatima Garcia Lorenzo from Philippines. A very warm welcome to each one of you. And my first question would be to Professor Dr. Vivekanand Jha, who is the Executive Director of George Institute for Global Health India and Chair of Global Kidney Health in the Faculty of Medicine, Imperial College London. He's a practicing nephrologist and leads a translational science laboratory at Postgraduate Institute of Medical Education and Research, Chandigarh. His research experiences include understanding the health and societal impact of non-communicable diseases, development of affordable and sustainable prevention tools, and health policy research. Dr. Jha, what additional actions need to be taken to make sure that shared value is measured with a people-centric lens? And what relevant approaches should stakeholders consider for greater impact for people living with NCDs?
Thank you very much, Shobhaji. And thanks to the NCD Alliance for asking me to come and join this wonderful panel discussion. I've learned a lot already from by listening to the panelists before me, and I look forward to more discussions. Now, it's been already said, Shobhaji, that COVID pandemic has really shown us the interconnected nature of social groups and stakeholders that might otherwise have very disparate individual goals. So it has brought with full force that we need to really think together and find common solutions. You brought up the issue of shared value, which is an interesting concept. It was first enunciated by Porter and Kramer in the context of economics, and talks about the need to pursue financial success in a way that yields social benefits. So let me take away the word financial and call it just success. We all need to pursue success together so that the societies are benefited. Now, the countries that are represented in this session, it's an interesting region where healthcare delivery systems are mixed and healthcare delivery models are also very different. But what is also notable is that throughout the region, there is a focus on economic growth. There is investment being made on infrastructure, goods and services, but not really so much on health, especially on non-communicable diseases and taking on board values and preferences of people living with non-communicable diseases. And so that is where I would like to draw the attention of the group here. What we need to do as a community is to invest in the message that health of the society is good for all. It's good for business, it's good for governments, it's good for civil society, which makes it a shared value between corporations, governments, societies, and also a valuable business proposition for companies. It's my belief, and I hope all of us will agree, that for collective impact on people living with non-communicable diseases, governments, private sector organizations, NGOs and civil society members and academia, we all need to collaborate for advancing health, and all of us have a specific role to play, but that role has to be for a common goal. Specifically talking about private sector, I think private sector participating in this process will need to find unique economic opportunities, and they will find unique economic opportunities that other stakeholders are going to miss if they take on the shared value approach. So what are the specific actions that these private sector organizations can take? Corporates should invest in healthcare and should not think it as part of a corporate social responsibility activity which they are forced to undertake or a kind of charity, but that it is a part of their core business. They need to leverage economies of scale and they need to bring in innovative approaches. It's essential, given who we are here as a group, that civil societies and people living with non-communicable diseases, we need to work together. We need to develop and present this value proposition and then work in partnership with corporates in developing the shared value and engagement framework, and also develop monitoring metrics. It is really only the people who are living with non-communicable diseases who can, from their lived experience, articulate how to address issues of inequity, including issues of financial access, quality of care, and highlight what aspects of care have a direct bearing on people's lives. We need to develop a consistent and constant communication system which reinforces activities and have transparent and visible metrics, which will be really critical to success. Now, representing the organization that I do, which is an academic organization, but also a civil society organization, we focus very heavily on solutions and actions. And one of the approaches that we take, and I propose to the group that this should become the norm, which is participatory action research. There are a number of examples which I can quote, but then that this is not specifically the point of quoting one specific example, but just to give you two or three, working with food industry to participate in consumption of healthy foods around the country in all societies. And there we need to work with civil society and self-help groups, etc., in villages, which we are planning to do. Working with transport industry to promote active, healthy living. And so therefore, what we need to do also is to ensure that all corporates understand that investing in employee health is good for productivity of the organization. We need to generate more evidence. That's critical, because evidence is what brings the point home. To make everyone understand what is of value to people living with non-communicable diseases, and also generate evidence around these shared goals so that evidence-based packages can be identified and invested in. What this will do is to bring the long-term social value and will contribute to the bottom line of governments, societies, as well as corporates. Such an investment will improve eventually the health and prosperity of the communities to which it is directed. This has to be done through always a multi-way learning and consistent dialogue, and therefore it's great that we are here talking to each other, and hopefully we will bring this message together and extend the conversation. I'm going to stop here and thank you for giving me this opportunity to share my views with everyone on this call, and look forward to the discussion. Thank you, Shobhaji. Back to you.
Thank you very much, Dr. Jha, and thank you for re-emphasizing upon the multi-sectoral and interdepartmental approach, which is very necessary if we have to avoid or at least mitigate the consequences of a pandemic and of people living with NCDs. So there are the food department and the food industry, the road industry, all are equally responsible and have to contribute. So carrying on the discussion forward, let us now hear from Dr. Lee Thi Thu Yen, who is Program Director at PATH, Vietnam Country Office, where she oversees the non-communicable diseases and other primary healthcare programs. In the past, she has also worked with Family Health International, Health Bridge Canada, and Vietnam's Ministry of Health as manager of the Community Health Promotion Programs. Yen, how can governments and other stakeholders, including the NCD community, implement a people-centered integrated approach to improve equity in the context of NCDs? And could you please share some multi-sectoral approaches achieving that in Vietnam?
Yeah, thank you, Ms. Shoba. Good morning, good afternoon, and good evening, everyone. So today I'm very happy to be here to talk and share some experience on multi-sectoral approach in NCD prevention and control that PATH have been carried out worldwide and also in Vietnam. You may know PATH is a global organization that has had a dedicated NCD portfolio for more than 20 years. And we are very happy to be here today. So I think you know that NCD are leading causes of death and disability worldwide. And it is more severe in low and middle income countries. We know many participants today in those countries. And in the past 2 years, people living with NCDs, including cardiovascular diseases, diabetes or cancer, have a higher risk of severe COVID-19 diseases and are more likely to die from COVID-19. And given the magnitude of the burdens, we know that no one party alone can prevent and manage NCD effectively. And the collaborations between governments, non-governmental organizations, industry, private and non-health sectors, and other organizations is essential and very much needed. And this approach ensures that the resources are used efficiently and the efforts are not duplicated. Efforts would complement each other's rather than that conflict or compete with each other's. So in Vietnam, the NCD also the leading cause of the mortality and morbidity, but the NCD response is relatively new and the public funding is still limited. And there is a clear need for the multi-sectoral collaboration in NCD control effort. And I would like today to share with you about 2 effective projects that have increased the access to care for the people at risk or people living with NCDs in Vietnam. The first project is the Community for Healthy Hearts, implemented with the support from the Novartis Foundation in Ho Chi Minh City, began in the 2016. The intervention models engage health leaders, the community, the public health system, and the private sector to improve the hypertension awareness, management, and control in Ho Chi Minh City. For your information, Ho Chi Minh City is the biggest city in the country. That is somehow is a business cities in Vietnam. The model has a community focus, bringing screening and referral services closer to home by setting up free checkpoint in convenient locations such as hair salons, tea shop, local market, or other community centers. In addition to increase access to hypertension screening, this checkpoint contribute to communities' ability to control their own blood pressure levels quickly and conveniently. And the second project named as Transforming the Non-Communicable Diseases Response aim to have Vietnam become healthier, supported by Access Accelerated, started in the 2019. And the Access Accelerated is helping to take the existing locally operating of the Community for Healthy Heart in Ho Chi Minh City to a national level by working together with the Ministry of Health to determine how the lesson learned and success from the models that we mobilize a lot of the collaboration from private sectors, from non-health sectors that can be implemented broadly across the country, and how to engage more sectors in the NCD prevention and control effort that can improve the patient outcomes. And we really work, the work is very effectively that the diverse multi-sectoral partnership can also transform the response from NCD by placing the person at the center of the response and finding innovative ways to respond to their needs and placing a focus on prevention and early detection to avoid serious and costly complication. And in summaries, we can say that those NCD work have been done so far in Vietnam with valuable support from the Novartis Foundation and Access Accelerated can help us to strengthening the primary healthcare system. And we found that within the public health system, the private healthcare system, and through the non-traditional access points, such as through the community volunteers or non-health sectors, has been a key pathway to increase access to care for people living with NCDs in country and in Vietnam and also other country that PATH has been working for.
Thank you very much.
Thank you.
Thank you very much. Our next speaker is Michelle Arby, who's the Global Head of Access to Medicine at Takeda in Singapore. Michelle started her professional career as a midwife and later joined the pharmaceutical industry. Since the last 13 years, she has been with Takeda in various positions. Michelle, how do we ensure that the COVID-19 pandemic is to be a turning point for action in terms of how all stakeholders, including private sector, revisit the concept of meaningful involvement of people living with NCDs in the NCD and UHC response? And also, what have been the lessons learned in terms of untapped collaborations between government, private sector, and civil society?
Thank you, Ms. Shoba, and thank you to NCD Alliance for creating the opportunity this afternoon for this important dialogue. I must truly say I'm very inspired by the dialogue as well as the passion from our speakers and our panelists, and privileged to be part of this today. So at Takeda, we believe that the private sector, and more particular the pharmaceutical industry, plays a very important role in the complex journey of achieving the Sustainable Development Goal, and that is of the achieving universal healthcare coverage. At Takeda, the focus of our access to medicine is in working in partnerships across the public and the private sector to help strengthen the health systems in order to broaden access, but also very importantly, to enhance the standards of care for people living with rare disease and the complex non-communicable diseases. So how do we do this? We do this by facilitating dialogue and aligning efforts between the stakeholders, as well as partnering with the government and the civil societies so that we can enable the access to highly innovative and quality medicines through contributing towards the building and broadening the capacity in local health systems. We believe that collaboration with policymakers on the creation of a people and patient-centric provision in managing these complex diseases and rare diseases is crucial in order to succeed. Very often, as we are aware, these rare diseases and complex diseases are misdiagnosed, as well as also often neglected. So one of these initiatives that we have taken on as an example within Takeda is working through with the Ministry of Health in Vietnam through a memorandum of understanding. And here we are helping to accelerate the diagnosis as well as the treatment for patients with hemophilia, as well as primary immune deficiency, two of the most prevalent rare diseases in the country. So the question might be again, so how do we go about this? So we do this by training the healthcare professionals, the implementation of a rare disease policy framework so that these products can be registered as well as enabled so to be defined within the rare disease framework, as well as securing policies for orphan drugs to enable supply into Vietnam. And very importantly is the empowering of the patients and the caregivers. As an example of how we are empowering or trying to do our best to increase the empowerment of our patients is we have conducted a pilot with the Ministry of Health through the healthcare professionals and the provincial hospital network in Vietnam to enable take-home therapy so that patients can get access to the medicine and drugs through their provincial hospitals, and they do not have to travel to the central city in the northern province of Hanoi to get access to their medicine. And as we know through the challenges that we have in the COVID situation, it was very difficult for patients not only to be diagnosed, but even to get access or travel to these central points where they can get access to their treatment. So this is just an example to show this is crucial for us to empower the patients so they can get access on a timely basis, as well as how can we continue with putting more of these initiatives forward, so to empower patients, to enable them to have the access not only, but the quality of treatment at the right time. Another example where we looked at how do we collaborate across the functions and even within Takeda and our partners was in Philippines. Within the Philippines, we had huge challenges within the infrastructure, the distribution channels, as well as the supply channels. And this is not unique only to us. It was an effect that we had across all of the industry, including that of the government and the private sector. And how could we get medicine to the patients on time, especially for patients that needed treatment for life-threatening diseases? It was not easy. And through the partnerships that we had, we actually came up with solutions that was out of the norm to ensure that we still align with the local regulations and the quality standards that we need to adhere to for our medicine, but to ensure that the patients do get access. And I'm very proud of the team and the local teams and all the efforts that they've done with the partners to ensure that not one patient was left behind that already on treatment, and that patients that were on treatment could get the access to these life-saving drugs to continue their treatment. Another aspect which also came forward is that of affordability. And I think affordability challenges is not something new. This is something that has been on the cards for a period of time and is a continuous challenge for us, especially in countries where we've got a huge segment of an out-of-pocket with a limited reimbursement. But what happened during the COVID and what we've experienced is even the burden was even increasing because of the challenge and the burden it was putting from an economical downturn perspective on that of the government as well as the patients. And we have put in place multiple programs of patient assistance programs across our countries in Asia that is based on affordability assessment so patients can get access and that it is based on what you can afford. And I think we continue with these initiatives across the industry and working with the NCD Alliance in close partnership and looking at the opportunities that we have to alleviate these challenges. And one of them was that of the eHealth in Philippines Alliance, which was in the support of the Civil Society Solidarity Fund on NCDs and COVID-19 to ensure of how do we bring the NCD plan and the access to patients on the agenda, even if as part of our COVID-19 response and recovery plans. So these are just a few examples of the importance that we see as Takeda in partnerships and collaboration across multi-sectorial aspects in order to work together across the divisions to bring solutions forward, because as one company and one entity, we are not going to be able to succeed in addressing these challenges. So we are committed to work in a continuous partnership and act as a change catalyst in helping to drive NCD and the universal healthcare agendas. And I thank you for the opportunity this afternoon and look forward to continue the collaborations which we have and many more to come as we look for solutions to address the challenges. Thank you.
Thank you very much, Michelle, and thanks for highlighting the pharmaceutical industry's contribution in this ongoing fight to control NCDs. Thank you very much for your reflections. I now invite Maria Fatima Garcia Lorenzo to share her perspective. Fatima is the president of the Philippine Alliance of Patient Organizations, an umbrella organization of 38 disease-specific patient groups representing about 1 million patients nationwide. Fatima advocates for patients' rights and is engaged in health policy development. She has also been caring for children with cancer and other chronic illnesses for over 3 decades. Fatima, from your experience, how can greater involvement of people living with NCDs be achieved in practice and result in improved health systems and outcomes for the people they serve?
Thank you, Ms. Shobha. Warm greetings to all. Thank you, NCD Alliance, for inviting PAPO to participate in this regional multi-sectoral dialogue. So as Ms. Shobha said, the Philippine Alliance of Patient Organization is a coalition of 38 disease-specific patient organizations advocating for universal access to healthcare and allied services. We aim to empower Filipino patients, including persons with disabilities, through education, networking, policy advocacy, and capacity building. PAPO is a member of Healthy Philippines Alliance and the International Alliance of Patient Organizations. We were requested to discuss how greater involvement of people living with NCDs can be achieved in practice and result in improved health systems and outcomes for the people they serve. We have observed that hospital, municipal, and national government leaders are more receptive to collaborate and engage advocates and NCD leaders who come from legitimate groups which practice good governance and are able to implement successful programs. It is therefore important for advocates and people living with NCDs to organize themselves and register their groups. Let me share with you an example of an engagement with hospital leaders. I have been invited to be a member of the Multi-Sectoral Governance Council of the National Children's Hospital, Philippine Children's Medical Center, and Valenzuela Medical Center. As members of the Multi-Sectoral Governance Council, we recommend relevant policies, programs, and activities to hospital management and provide strategic assessment of the hospital programs, especially in addressing COVID-19 concerns. I was invited to be a member of the Multi-Sectoral Governance Council because of my role as Executive Director of KITE Foundation. KITE is an organization which has been providing child life services and financial support to children with cancer for the past 29 years. Kite is a member of the Union of International Cancer Control. Advocates and people living with NCDs can engage local government leaders through the local health boards. Some function of the local health board are to propose, in accordance set by the Department of Health, the annual budget for the operation and maintenance of health facilities and services and address COVID-19 concerns within the municipality. I Can Serve is a foundation which supports people with breast cancer, and they have been successful in engaging local government leaders. Through their powerful programs for breast cancer patients on the ground, they have been able to convince the local health board in Taguig City to pass ordinances to institutionalize breast cancer and patient navigation programs. And so, the breast cancer programs continue to be implemented in the municipality despite the COVID-19 pandemic. In the national level, about 18 formalized and registered groups form the Healthy Philippines Alliance. The Healthy Philippines Alliance is a group of organizations and individuals working to protect the rights of people living with NCDs and promoting health in all policies. The Alliance recently pushed back attempts in Congress to ease tobacco control policies. Furthermore, the Alliance monitored and engaged policymakers to implement NCD-related laws like the Universal Healthcare, National Integrated Cancer Control Act, the Sin Tax Law, and formally engaged policymakers about the challenges of people with NCDs during the COVID-19 pandemic. Greater involvement of advocates and people living with NCDs in health policy making and systems change can happen if they belong to formalized and registered groups, are given opportunities to learn more about their disease, taught how to navigate their country's health system, and empowered to engage health and government leaders in a meaningful way. This is the reason why we in PAPO provide capacity building workshops to our member patient groups. We have had a series of workshops on universal healthcare, health technology assessment, and clinical trials. This year, PAPO has been holding webinars to address infodemic and vaccine hesitancy. Our partners in the region like Raj of Rainbow Across Borders from Singapore and Ekawat of Hemophilia Foundation Thailand created training modules and invited me and Kenneth Ma of Rare Disease Disorder Society Singapore to share our best practices with startup patient groups in Thailand. This online training happened for 2 weekends last May 2021. Modules range from how to create the group's vision, mission goals, and how to conduct strategic planning. Other topics focused on fundraising and how to register groups with local authorities. The training group hopes to share their experience and knowledge with more startup patient groups across the region. NCD leaders from mature groups helping NCD leaders with startup groups. Perhaps this can be one of the recommendations to move the NCD advocacy forward and address COVID-19 issues in Southeast Asia and the Western Pacific region. Thank you.
Thank you very much, Fatima, for sharing such good best practice examples which you are implementing in your country and which I think we need to take up all at our own level in our own countries. Thank you for your reflections. And with this, we come to the end of our second panel discussion that explored solutions to mobilize communities in our region for a people-centered response for NCDs in the COVID-19 context. Now I invite M. Brandon Artong to set the tone for the second fireside chat with his intervention. Brandon is Head of Public Policy and Advocacy at the Fred Hollows Foundation, Australia. His work spans prevention, early intervention, Indigenous health, disability, and development within the Asia-Pacific region. He has also been promoting the human rights of visually impaired people for several years. Brandon, having heard the perspectives shared by the panelists today, what would be your recommendations to take these approaches forward in Southeast Asia and the Western Pacific region?
Thank you so much. And it's been such a rich conversation with so many different perspectives brought into this conversation. But I'm pleased to see that there's been a few very strong themes coming through, which I'd like to touch on in a second. But can I indulge and just quickly touch on the situation around eye health? And for those of you who don't know, the Fred Hollows Foundation is an international development organization working in about 25 countries, including in both these two regions on this call, around eye health and health systems. In terms of the global context of eye health, probably people aren't aware that around more than 2.2 billion people around the world currently living with a form of vision impairment. 1.1 billion of those people have a condition which has yet to be addressed or could have been prevented. And of those, around about 43 million people are living with blindness, and probably just under 300 million with a form of vision impairment which is severe or moderate, causing issues in daily life. When we look at the prevalence around the world in the Western Pacific region, in South Asia, East Asia, and Southeast Asia, we see the highest prevalence of blindness and vision impairment. And the vast majority of which is caused by cataract and refractive error, two conditions that we know have cost-effective interventions in cataract surgery and the provision of spectacles. And they are both NCDs as well. We look at the challenges that are persisting around eye health. We see that there are changing population demographics, for example, aging populations and growing populations. We see that data collection and inclusion of eye health data within health information systems, eye health within health strategies and plans remains a bit of a problem. We know that workforce, the distribution of and the size of workforce is an ongoing problem. And of course, engaging with the private sector and interaction between the public and private sectors. But across all these is the issue of equity. We know that that equity is a key issue in blindness. We know that women and girls are more prevalent in blindness rates. Some 55% of people who are blind or vision impaired are women. We know Indigenous people are often left behind, people with disabilities, people living in rural and remote areas. And if you look at COVID, the situation with COVID, we've seen that elective surgeries for things like cataract have been deferred. We know that other health services like provision of spectacles has been deferred. We know that the eye health workforce is being redeployed into other areas. Eye health hospitals are being redeployed. We can see issues around, for example, diabetic retinopathy, which is a complication of diabetes, where there are people not being able to manage their diabetes well. We know that will lead to blindness going forward. Some 1/3 of people living with diabetes have some form of retinopathy, and about 10% of those people will have a form of sight-threatening retinopathy. So we see that COVID is actually having a higher impact as well. And again, when you look at the risk factors around COVID, older people, of course, are more at risk of having severe illness from COVID, but of course, the same cohort of people who are also at risk of developing eye conditions. 76% of people who are blind or vision impaired are over the age of 50, and that goes up around, it doubles around about for each decade over the age of 50 as well. Looking specifically at people and the experience of people living with blindness and vision impairment, in this COVID time, social distancing, access to information and the constantly changing environment has been a real struggle for people living with blindness or vision impairment. Just think about the idea of social distancing. You need to be able to separate yourself from the nearest person next to you and know that they're there in order to be distant. which is an issue for people who are blind, who often use touch in order to interact with the world around them. Information is such an important yet fraught area around access for people who are blind. It's always difficult to get access to information, but even more so in times of crisis. So if you put these into perspective, we can think of social norms and attitudes. We can think about accessibility of spaces and information, and the predictability of spaces and environments has always really been a problem in access to healthcare for people who are blind and vision impaired. So when we think about mobilizing people and communities towards engagement with NCDs, I think we've got an opportunity here, which is another theme that's been coming up throughout the day-to-day, is around capitalizing on the opportunity. I think we have an opportunity to rethink how we reestablish norms and attitudes around people and person-centered approaches to healthcare, including people with disabilities. Advancing accessibility of spaces, environments, and information. And I think that we can try and think through how to make accessing services more intuitive and something that we can do without having to trawl through many different spaces. It doesn't need to be a lottery of luck in order to access services. So if I think about the themes that have popped in my head from the discussion today, I reckon there's probably about 3 key things. One of them overlaps a lot, and collaboration in whatever form that's been discussed today, collaboration, whether it be collective action or so forth, seems to be a really important theme coming out across the conversations today. And within that, there is, elements of, cross-fertilization from government to non-government to private sector, thinking about, as Dr. Charles said before, looking at value propositions and building evidence. Linked to that, of course, is thinking about this as a cross-sectoral, multi-sectoral approach. And I think Dr. Yen spoke about this before, really importantly, that we need to look not just at the normal friends and spaces, but look beyond those spaces in order to engage. And the last two, I think, one is around empowering people, really important, and Michelle picked up on that, but also engaging people and communities as well. So empowering people is really important. And I think linked to that, which came up through Maria's presentation just now, was having the legitimate voice to government of people with lived experience, of people with disability, and to see that as an opportunity and a strategy to engage government and to persuade along the right lines. I think I'll leave it there. Hopefully that was what you were looking for. Thanks so much.
Thank you, Brandon. Thank you very much for bringing up the problem faced by the visually impaired, who are often put on the blind spot, if you will excuse my saying so figuratively, and also for sharing solutions to their problems. Now we are really running short of time, so I will just take up one question very quickly, and that question is for Professor Jha. He had to leave early because of certain commitments. So he has just left in his answer in the chat box, and I will read out the question and answer to you all, especially for the benefit of those who are watching this on Facebook. So the question is, could you please elaborate more on participatory action research? It sounds like an effort to get industries to participate in research that will help provide data to prove that investment in health of their employees is for their own good. Is that accurate? And Professor Jha answers this question by saying, participatory action research involves all stakeholders, including industries, to be involved, research together to understand a problematic situation and change it for the better. The focus is on social change that challenges inequality, is context specific, targeted on the needs of a particular group, and uses local resources, can be adapted according to learnings and reflections, and empowers all participants to have a greater awareness of their situation in order to take action. With this, we now are nearing the end of our dialogue for today. Listening to the speakers has really raised our hopes for a healthier tomorrow despite COVID-19. Yes, the pandemic has been an eye-opener for all of us, those who got the virus and even those who did not. Access to treatment and care for other diseases was greatly impaired during COVID-19. Clearly, the impact of this pandemic would have been much less disastrous if we had stronger public health systems with a strong community focus and had also made the desired progress on every goal and target towards sustainable development. We set the seeds of our own destruction by not having universal access to quality, affordable healthcare as a minimum basic human right for every person on this planet. And we are paying a huge price for it now in a pandemic for the lack of it. Access to care and treatment of all diseases, including NCDs, must be an important part of health systems response, pandemic or no pandemic. Outcome of COVID-19 was predetermined by our health history, whether we have years of poorly managed underlying NCDs or health conditions like hypertension, diabetes, which have been associated with serious outcomes of COVID-19, including death. People living with NCDs who were infected with the virus faced more severe outcomes, and those who did not get infected struggled to access basic treatment and medicines for their existing medical conditions, as was pointed out by many speakers. Outpatients departments in many hospitals were shut down, at least in my country, that was happening. Dialysis and chemotherapies were disrupted or not available at all. Elective surgeries for cancer, heart, and for eye conditions, as has been mentioned by Brandon, were postponed. In my own family, a heart patient died because the hospital refused to admit him unless he got an RT-PCR test done and showed the report. But there was no time for it. He would have lived had he got immediate medical intervention. And this is not just a one-off case. Our ability to cope with an epidemic depends upon the strength and resilience of our healthcare system, which takes years to build and just weeks to break if it is not strong, as the pandemic has shown. Countries that have done better in dealing with the pandemic are those that have invested in basic primary healthcare, in social security, in community-led health responses, and in much better distributed public healthcare infrastructures. We also need to ensure that progress on health security does not get undermined by corporations who profit from illnesses or from selling products that make people sick. Corporations that have knowingly deceived our populations in consuming products that make us sick and kill must be held legally and financially liable. I firmly believe that the only possible way forward to prevent NCDs and avert untimely deaths has to be a feminist way, a feminist fossil fuel free future, the 5 Fs, based on solidarity and caring is the only way forward. A feminist health system is one which is socially just, ecologically sustainable for everyone, everywhere, so that we can genuinely deliver on the long overdue promise of health for all. Women are acknowledged as the primary caregivers in families, yet little attention is paid to their own health. So most of them get medical care, if at all, at a very late stage, which proves disastrous. We have to make people a part of the solution to deal with the disease. Decision-making processes at all levels must include voices of the communities and people most affected, and integrated health responses and services, including preventive health services, should reach all: men, women, transgenders, LGBTI, and other marginalized communities. A people-centric feminist approach to improve health-seeking behavior, as well as access to prevention, treatment, and care is key. Let us stay united in our fight against NCDs to build a fairer, healthier world for everyone. And together we can. I would like to thank all the speakers for enriching this dialogue with their invaluable reflections. And of course, to the audience for their lively participation. Special thanks to NCD Alliance and Takeda for organizing this wonderful conversation. Inputs from today's discussions will feed into the Global Charter on Meaningful Involvement of People Living with NCDs, which is expected to be launched in September. Thank you once again. Stay safe and stay healthy.